Think, talk, laugh. Piensa, habla, ríete.
Welcome back to 55 KRC, the talk station, and Think, Talk, Laugh. We're so glad you joined us today. We are glad to have in the studio with us, as we alluded to at the first break, Dr. Ryan Stanton. Ryan's got a fantastic resume here, and I won't go through all of it, but just to say, in 2012, he was the National Spokesman of the Year for the American College of Emergency Physicians. He's been ranked as one of Lexington, Kentucky's Young Professional Rising Stars. Grateful you joined us here in the studio today. Welcome, and we're glad to have a real doctor. We really, as you were sitting in here in the first segment, we've been talking about this intake coordinator. You've got obviously a lot of experience working in emergency rooms, and you were explaining to us that there's really a front end and a back end. Maybe you can kind of kick this off by explaining that there's really two intake coordinator positions inside of the ER room.
Yeah, the ERs are very complicated based on what type of ER you go to. I mean, if you're going to a little community ER out there, it's a small little ER, still very mom and pop type stuff. Whereas if you go to a university hospital, which you've got here in town, it becomes much more complicated and much busier. And so what we're talking about is two separate things. The intake, which is our registration and triage and those sort of folks that get the baseline information we need. And then the back end, which is the intake coordinators, which you're kind of referring to, which they're the ones that once I decide that somebody needs to be admitted, then they help me get the bed and get the location they're going to go, because it gets really complicated with how busy hospitals are now. We have fewer hospitals, fewer ERs, but more people using them. The beds are of a premium, so it's hard to find a place to get people to go.
So how important is it in your view that the different patients who come through the door provide information to those intake people so they're as accurate as possible so you can treat them? What do you see in the sense of the emergency when it comes to those situations?
Oh, it's integral, because I have, on average with our patient flow, I have 15 minutes to learn everything about you and come up with an answer as to what's happening with your emergency. Now, it's spread over a couple of hours, but it's about 15 minutes. So I have to have all of your information. I have to meet you and learn everything about you in really about 3 or 4 minutes, and use that information to guide where we're going with our evaluation and finally our disposition. We kind of alluded to the fact that if I don't know something about you, a complicating condition, it can make things really difficult on you if I don't know about it before the discharge. So if you come in with chest pain at age 40, and I just work you up as a 40-year-old with chest pain thinking there's no big risk, and you forget to tell me that every one of your siblings died at age 40 from a heart attack, that's key information. I've got to know that. And so really the most important thing for everybody I recommend is that you have the information with you. You mentioned having a friend or a family member, but really you don't schedule emergencies. You don't plan when you're going to get sick and die. So when you come into the ER, you have to go to the ER. You have to have that information with you. So a card in your wallet, what we call an ICE card, or in case of emergency card, that's got the basic information, your health history, your medications, your allergies, that's key. Stuff that we know that can make a big difference in those first 15, 20 minutes. And then in your cell phone, have a contact. If you have a spouse, label them as husband or wife. That way we know who to call.
Folks spend in the ER or being able to get some of that information.
Substances are a huge problem for multiple reasons. One, they can mask legitimate emergencies. So I do a lecture series with all of our EMS guys that is, they could be drunk or they could be dying. And so it's being able to identify whether they're drunk or whether they have something serious that needs to get to the ER immediately.
So does a breathalyzer or some sort of immediate test help distinguish
if they can.
that? Or?
The issue is if they're that drunk, if they're really significantly altered, they can't do the breathalyzer. And so that's how a lot of people end up with us. So then we'll start doing a blood alcohol test, which takes 45 to 50 minutes, which is 45 to 50 minutes into that magical hour that the person needs. And so we have to treat based on suspicion and based on evidence rather than based on
I would have thought they would have had
numbers.
Something quicker now for
well,
that.
Unfortunately, there's not. I mean,
No,
a lot of the labs.
I'm in point of care, diagnostics. So I'm just like thinking, I'm like, wow, really?
Yeah, point
okay,
of
I'm
care
going to write that
point
down.
of care is great for positive or negative, but it's not good for quantitative.
Right. No.
So most people, we had a stroke we saw one time that the alcohol ended up coming back at 50. So it still would have been positive, but it wasn't positive to the point that it should have led to the symptoms that brought him into the ER to see us. And so breaking those apart. And then substance abuse issues where they don't want us to know. They come in with chest pain. Do you use cocaine? No, I don't. Oh, wait, your drug screen came up positive for cocaine. You use cocaine? Oh, somebody must have put it in my drink 2 weeks ago. No, they didn't put it in your drink 2 weeks ago. When did you use it? Oh, I have yesterday. No, when did you use it? Your hands are still red. Oh, okay, about an hour before I got here. Okay, there we go.
Like that misdiagnosis occurs from misinformation.
It is, and it's just like right now in our studio right here. If I look outside and say, what temperature is it? It's nice and sunny. It looks like it's It probably looks like it could be 75, 80 degrees. But
Actually,
we go
that's a
outside.
mural, Dr. Stanton.
We painted these people into that mural.
Very
you know?
realistic, very realistic. And so what we do, we have to come up with a diagnosis based on the best information we have.
Right.
And I can walk into a room and say, okay, I'm going to order one of everything.
Right.
But we don't have the time, the capacity, or the money to do that.
This was a fantastic effort of Dr. Stanton. We appreciate you coming up. We appreciate you listening